to seminars in ophthalmology. Tonight, we're focusing on an important and clinically relevant topic, HIV and the eye. HIV can present in diverse and sometimes sight-threatening ways, and early recognition plays a critical role in protecting vision. In this session, we'll explore common ocular manifestations, identify urgent referral red flags, and examine how immune status and antiretroviral therapy influence disease patterns. We'll also share practical, structured approaches to assessment and management that you can apply confidently in everyday clinical practice. And don't forget, our ophthalmology micro lesson is available on the Clinical Care Platform website, along with a wide range of additional learning resources. If you're not yet an annual member, this is your opportunity to unlock full access to webinars, micro lessons, CPD accredited content, and exclusive professional benefits. Thank you for joining us. Let's begin.
Yay. Good evening. Welcome to the Clinical Care Platform. Let me find it. Where is it? Yay, colleagues. It's such a great honor to host you as always. It's a Tuesday, and we are kicking off our educational programs for the next 3 days, every Tuesday, Wednesday, Thursday. And guess who's here with us? Yeah! Dr. Mofokeng. When you see him, it means you don't need him. If you don't see him, you need him, because it means something. Hey, Dr. Tabiso, how are you, sir?
I'm good, thanks. How are you, Dr. Mofokeng?
Yeah, just happy to see you, man. It's been hectic, man.
Yeah, same here. It's been a minute.
Hey, yeah, we've been very hectic, man. But thank you so much.
Yes.
No, thank you so much for making time to be with us because you are a person of value. And you have committed to share that value with us, and we can never say no, So I just wanted to say thank you so much. Colleagues, this is Dr. Thabiso Mofokeng. I'm going to share his profile. I won't read it. I will tell you what he means to me. He's a very, very, very cool guy, very simple. We connected, and since then, the rest is history. I mean, he's our in-house ophthalmologist right here at Clinical Care Platform. He's a qualified medical doctor, ophthalmologist, He has the postgraduate diploma in ophthalmology, and because of his passion for teaching, we now have a coaching program that helps doctors, to register and to write the exams for ophthalmology. We had our first cohort in that group, and we can't wait to hear all the feedback as people are already writing the exams. So we really appreciate you, Dr. Mofokeng, for the webinars, for the master classes that we have had, but also for the diplomas. So if you are here and you love the eye, Dr. Mofokeng is your guy. Dr. Mofokeng is your guy. Yeah. So yeah, let's leave it at that, except to say welcome to you, Dr. Mofokeng. And colleagues, just to remind you that we are a membership platform. Do join the membership, support the platform, so we can always continue to bring you these great educational programs. And also to say, this coming Saturday, we have a master class in medical emergencies. So if you are an internist, you like internal medicine, or you work in casualty, you may not want to miss that master class. But let me not spoil it. Today, our focus is the eye. Actually, you have the right people here. Do you see, Dr. Mofokeng? The eye and the HIV guy.
Yes, yes. That's definitely. I'm going to at least learn quite a few things from
Yeah.
on that side, that aspect
That's
of
interesting. I
HIV
didn't see it
side.
that way. So, colleagues, today you are dealing with HIV and the eye, if you look at on your right hand side there. Yeah, so let's hand over to Dr. Mofokeng to take us through today's session. Thanks, brother. You may share your slides and then take us through. Welcome, colleagues.
Let me see here. Also, I should go back to share again.
Yes,
Okay.
yes.
All right. Share.
Awesome.
Okay.
Slides are coming through slowly. We can see your slides. Thank you so much.
Okay.
Yes.
All right. Okay. Let's just without any much further ado. Good evening, colleagues, and welcome to our first seminar of ophthalmology for 2026. And then we start with a very important topic, HIV and the eye. I must make it clear that this lecture, I actually prepared it for the guys who are writing the diploma, even though I had to do one or two editions there and there. So there's a lot of slides, but don't worry. Some of it, it might be a bit too detailed for our discussion today. So the point, by the time we are done here, is that I want all of us to be able to identify various conditions that affect the eye because of HIV, because some of these conditions, or most of them, they are sight-threatening and to a certain extent even life-threatening. And the point of entry with most of our patients, it will be their primary health care provider, their general practitioner. And so I think it will be of value for us to go through this. Now, just a simple gross anatomy, just to remind ourselves. So basically, the eye, when we look at the eye, the outer surface, we've got the upper and the lower lid. Beneath the lid, it's the superior fornix. Beneath the lower lid is the inferior fornix. This is our clear cornea. This is the conjunctiva overlying that white sclera, what we refer to as the skeleton of the eye. So on cross section, we obviously usually divide the eye into an anterior segment, anything above the lens, and the posterior segment, everything behind the lens. So vitreous body, the retina, the choroid, and the sclera, that will be part of the posterior segment together with the optic nerve. Now, the discussion will be based on this, the parts of the eye. So we'll look at the eyelid, look at the anterior segment, and look into the posterior segment and discuss various conditions that affect these different sides, So starting with the leads, we'll start with Kaposi sarcoma. It's a vascular tumor. Because of it being vascular, it will always appear purplish bluish in color, and it can affect the skin and the mucous membrane. So, I mean, obviously, things like your conjunctiva. And I won't go much on to the pathogenesis, but it's important to note that it is caused by what we call a human herpes virus subtype 8. For us in our setting, we see this thing in Kaposi sarcoma in young patients, and invariably, almost all of them, it's kind of HIV/AIDS associated. So with KS, what we see most is that they're actually immunocompromised or immunosuppressed. We find that their CD4 count is also low. And some patients may present you for the first time with this kind of lesion, and they don't have any other symptoms. That's when the discussion must start saying we need to do a further workup and to do an HIV test as well. But fortunately, most of our patients are on treatment. We don't see Kaposi sarcoma as much as we used to see it like, let's say maybe 10 years or so ago, or even longer. Now, the clinical features, like I said, it's a purplish bluish nodule on the lids, but it can also affect the conjunctiva. And on the conjunctiva, they have what we call chemosis, edema. Now, the issue with the conjunctiva, that's where the problem is. With the conjunctiva, it is very easy to miss Kaposi sarcoma. It can present as what seems like a subconjunctival hemorrhage. And if one is not vigilant and notice that there is a nodule behind that subconjunctival hemorrhage, you can reassure the patient and send the patient home. Whereas, we should have actually done a further workup. So features on the conjunctiva, bright red to purplish, but mostly bright red. It can be flat or nodular. And as I've already mentioned, it may mimic subconjunctival hemorrhage. It's mostly located in the inferior fornix, but it can occur anywhere. So for me, what's important is that when you see a patient presenting with a spontaneous subconjunctival hemorrhage, you must obviously look out for those nodules. It's for the nodular subtype. I mean, usually that's what they present with as well. But over and above, think about it, because it can simply be a subconjunctival hemorrhage and nothing else. But if it's a young patient, there's a history of immunosuppression, just be a bit more on the vigilant side. And then we are going to move on to another entity, the lymphoma. So with the lymphoma, we'll talk about the conjunctival lymphoma, but we'll also discuss towards the end the intraocular lymphoma. So what's important to note is that it can present de novo. So like it might be the conjunctiva might be the primary site, or it might be an extension from an intraocular spread. Or even more important, it can be a spread it may be a systemic spread from a distant, like it might be a met to the conjunctiva. Really, it might also be from the benign lymphoid hyperplasia, so it might transform to undergoing malignant transformation. Why I'm emphasizing these things is that if one has features of what seems like a conjunctival lymphoma, of which we will discuss, and I'll show you some pictures, you need to be able to do further tests and to obviously refer to oncologists, or usually the oncologist will be the one that will do the workup to see whether there's no systemic involvement. Or like, of course, I mean, if the patient is with an ophthalmologist, usually we will interlink with the other disciplines. I won't go much about the types. For the guys who are going for exams, it's usually important for them to know that the common type is a B-cell non-Hodgkin's lymphoma. So what's important is in terms of who are the patients who are susceptible to getting this. So we already know that we said it's immunocompromised patients or older patients. It can present as a conjunctival mass. It's usually painless. It's slow growing. This is very important, what we call the salmon patch appearance. And often than not, like they say, it's usually unilateral. But about 20% it can be bilateral. And then it can really present as a diffuse lesion masquerading as a chronic conjunctivitis. So the thing about these HIV-related eye disease is that, they're the greatest or biggest masquerades. That's what we actually refer to them as. Now, here's what I was referring to when I say salmon patch. So for those of you who like salmon, maybe you'll agree with me that this it has an appearance of a salmon patch, but that's how they describe it actually. And you'll see there.
You just don't want us to eat salmon, Dokotela Aubatung.
No, actually, interestingly, when I was reading this in my early days, I never knew what salmon looked like. So I never used to understand. And then whereas there was salmon at home, but I didn't know actually this is because I'm not a big fish person. But yeah, this is a salmon patch. And then we also look at what we call corkscrew vessels. The feeder vessels. So anyway, let's see. So I mean, in terms of the management. I don't think that's obviously that much of on our tele now, but it's important to know that, if a patient has what might be presenting as a diffuse conjunctivitis, you must look out for this salmon patch because, I mean, these patients will obviously want to send them through to undergo what you call an excisional biopsy. Because when you excise them, it's also kind of therapeutic as well. Now, this one is a big one. I'm going to go to a bit on detail with it because it's kind of a common problem in our setting, what we called ocular surface squamous neoplasias. So this is a spectrum of malignant and premalignant corneal epithelial tumors. Now, it's important to note that there's those three types, the benign, pre-invasive, and invasive. And so basically, when we say pre-invasive, so this is the epithelium, the dysplastic cells, so the cells that are abnormal, will be confined to above the basal lamina. So if ever it's affecting a third of the epithelium, we'll say this is mild. If it's affecting 2/3, unless it's moderate, if it's beyond 2/3, we'll say it's severe, severe dysplasia. But then if it's affecting the entire epithelium, but sparing, but not transversing through the basal membrane, we'll say this is carcinoma in situ or conjunctival interepithelial neoplasia. So CIN, basically. These types of descriptions are obviously very important because when you get a report, there's different ways that we treat these lesions. But then why am I saying this is important? Because in sub-Saharan Africa, as in like South Africa being one of them, this disease is associated with HIV infection. And it has nothing to do whether the patient has a CD4 count of 200 or 400. We see it even in patients who are immunocompetent. So it's important to note that if we have a patient with a lesion on the eye that has features that are in keeping with ocular surface squamous neoplasia, we need to give them counseling so that we can obviously work them up further for intervention purposes. So benign, I've already described it. And then pre-invasive, I've already described it. So once it traverses the basal membrane, it's now regarded as a squamous cell carcinoma, SCC. But now with this new classification from Shield and Hesh, so we call it invasive ocular surface squamous neoplasia. But when we get our reports from the pathologists, the histopathologists, they still say it's SCC, squamous cell carcinoma of the conjunctiva. Now, this is a repetition of what I've already said, just to show the illustration in terms of what we were saying. So this is normal. You have a bit of dysplasia. This is the entire epithelium. As it gets worse, it becomes moderate. As it traverses the entire epithelium, we'll say it's severe, or what we call CIN as well. Now, for me, what is important for us to remember is what are the risk factors of patients that will have ocular surface squamous neoplasia. While in sub-Saharan Africa, like I said, most of our patients, it's HIV related. Some studies have implicated the co-infection with HPV subtype 16 and subtype 18 as well. UV light exposure. So this is where you'll find in your Australia, Europe, even in Africa, in South Africa, I guess, especially in the older patients. So that's why they say we've got two clinical presentations. But my interest will be on the HIV related, and this is the majority of what we see. During my days as a medical officer in ophthalmology and even as a registrar, there wouldn't be a week where you don't at least see 2 or 3 suspicious lesions, such that every day in the theater list between from Monday to Friday, there'll be 1 or 2 or 3 patients that are having to undergo excisional biopsy. So it's important, like I already mentioned, it's HIV related. So how do these patients present? The lesion is usually in the interpalpebral space. So basically between the lids, between the upper and the lower lids. Usually they'll have, it can be gelatinous, leukoplakic, papillomatous, but they have this what you call feeder vessels that are corkscrew-like, and sometimes there can be a bit of pigmentation. But like I say, the main thing, it will be this leukoplakic, gelatinous, or papillomatous lesion. Now, here are some pictures. So how do you talk about leukoplakia? So this whitish lesion, and this will be, like so I mean, sometimes one cannot be blamed to confuse this with a lymphoma, but this is your gelatinous type, and then when you talk about the corkscrew vessels, I couldn't get a nicer picture of, like, you can even see them going like a corkscrew. Those who use wine will know what I mean when I say corkscrew. So, like, yeah, those corkscrew feeder vessels, and so, like, sometimes it can be diffuse and flat, but the more you see these lesions, the sooner you'll be able to pick up that this is suspicious. So usually we'll say it's a suspicious conjumus because you don't have the diagnosis, and then when you submit to I always refer to them as the clever doctors, because they're the ones who help all of us to diagnose these things. They'll tell you whether it's invasive OSSN or not. So the investigations, like I said, this, I wouldn't dwell much into it, but we have what we call, in our setting to start with, all our patients, they will go for an excision biopsy, because excision biopsy, it's therapeutic and diagnostic. So our basically, what was the word, basically, for our mainstay of diagnosis, none of these things will help us. Mainstay of diagnosis, you want to have what you call a tissue diagnosis. But in ophthalmology, we've got a few imaging that we can use, like, for example, ultrasound biomicroscopy. For me, it usually will help us, especially after you excise the lesion and the report comes and say the margins are not clear or it's an invasive OSSN. So you can follow these patients by doing this ultrasound just to see if ever there's no intraocular spread. High resolution OCT as well. Patients, sometimes we've got a long waiting theater list. So, but you want to just assess by doing an ocular coherence tomogram. I'll show you the images. Impression cytology, we don't do much of it because most of our pathologists are not that, I don't want basically, they're not, in terms of cytology, we just prefer having the whole tissue, unless if ever you have someone you have a close relationship with that they can help you with the cytology part. But like I said, this is more for academic reasons, and I'm just mentioning it. What's important, like I said, okay, so when you do things like impression cytology and you send these things for what you call a tall blue, we don't use that, but it's just for those who didn't manage to go to theater. You can use this tall blue as a screening to if you suspect invasive OSSN, or even the pre-malignant ones. And then here, basically, that's when we talk about the imaging, when I talk about that ultrasound biomicroscopy, and then you can see that there's a lesion, it's on the conjunctiva. Sometimes you find that the lesion has been excised, but you think that there's corneal stromal involvement. that obviously helps you to see that, you know what, maybe this patient needs to continue to be on topical chemotherapy just to be sure that there is no therapy, is excision biopsy. Now, when we take these patients to theater, we want to have at least, so we need to submit to the pathologist. The report will tell you if your margins are 2 millimeters, 3 millimeters. But because in our setting, our patients sometimes present late. This we usually do what we do cryo freeze. So the remaining conch, we do a 2-row thaw freeze just to make sure that we kill any remaining cells. We don't use mitomycin C. But these are just adjuncts. If it's an invasive OSSN, there's only 1 millimeter clear margin. So you want to say, you know what, just to be on the safe side, I'm going to put this person on topical chemotherapy. So the one that I'm familiar with for us is the 5-FU, 5-fluorouracil. MMC, which is mitomycin C, it's an antimetabolite. We use it for other things, not so much, but it can also be used as an adjunct for you to treat if ever a patient had a lesion that was too big for you to excise everything. Now, I don't necessarily like using scare tactics, but I always want to say what goes wrong if ever these things, there's a delay. Now, most patients, especially our male patients, and maybe I must also disclose that I did my thesis on lesions of the conjunctiva, so I having an exenteration. By the time they come, and it's very painful, this person comes with a vision of 6-6, but you do an ultrasound B scan, you find that there's invasion into the globe. You send them for a CT scan, you'll find that there's invasion of the optic nerve, sometimes the alien invasion of the optic nerve. So what do? You remove what we call an exenteration. It's such a barbaric procedure, and most patients who undergo this thing, like I say, it's male patients. And I'm talking about male patients living in the suburbia, not that they can say there are no hospitals in my area. For a person to end up with this, you must just know that he had this lesion for at least 7 to 8 years. It's not a like, fast growing tumor. But anyway, so we don't want patients to end up with this, where a person can have what we call an excision biopsy, and the treatment, the tumor has been removed and vision maintained, cosmetically acceptable. And you know, we need 2 eyes for us to have what you call stereopsis and proper vision and proper visualization for you to be able to drive properly. You know, it goes like it's one of those things that sometimes breaks my heart, because sometimes the patient comes, you tell them this is what you have, and then they disappear. They don't patch up for their procedure. A few years down the line, now it's an ugly looking tumor. So if you don't have, sometimes you don't have to do an exenteration, we do what we call an enucleation. So you remove the entire eye, but you leave the adnexa behind. So you leave the muscles behind. So I'm just showing this because, I mean, you know, patients will trust their primary healthcare practitioners. I mean, I was in that space for many years. So it's just important for you to say, you know what, I'm referring you to hospital because I'm suspecting that you have uh, a tumor in your eye. It might, and this tumor is easy to treat if ever we act quickly, you know. So I wanted to say that our female patients, usually they present with mild to moderate ocular surface squamous neoplasia, but our male patients, they present with SCC that's invading the globe, and sometimes there's even lymph node metastasis when we end up with this situation. All right, so yeah, timeless intervention basically. So now we're going to go to the infections of the leads, starting with herpes zoster ophthalmicus. We all remember is from the HSV virus. It's caused by, it's a double-stranded DNA virus. We don't have to go to details about that. Like I said, these were prepared for guys who are writing exams. So often than not, as kids, almost all of us are exposed to chickenpox. But this, it heals, but it lays dormant in the dorsal root ganglia. And for whatever reason, once our immune system becomes weak, whether a person has aged, but of course, in our setting, we know HIV as well is one of the biggest contributor to this. So now, the mechanism of ocular involvement, I won't go deep into that, but what I like about this, it talks to how we treat these patients. So it can be a direct viral invasion. That's why we will use an antiviral. But there's also an element of secondary inflammation. That's why as soon as we have the diagnosis and the patient is suitable for anti-inflammatory, usually we'll have to use a bit of steroids. We'll add that. And of course, there's an element of reactivation. Now, what are the risks that you want to look for to say this patient has herpes zoster ophthalmicus? So there's involvement of V1, so it's a branch of the trigeminal, the ophthalmic. Usually it's the nasociliary branch of the ophthalmic. So the ophthalmic nerve has three branches. So the nasociliary, lacrimal, and the frontal. So the nasociliary, once it's involved, these patients will present with what you call the Hutchinson sign. So this patient comes to you, he's got herpes zoster ophthalmicus. What I'm not sure if they still use that word as well of a belt, lebanda, ibanda, yeah. It respects the midline. It's obviously a dermal. We'll have to send you for an ophthalmic assessment. You are in a medical ward, you're treating a patient with this, consult ophthalmology. And when in your consult, you say, I'm worried this patient has got lesions on the tip of the nose, he's got a positive Hutchinson sign. And so that is a strong correlation with subsequent eye involvement. Of course, I mean, patients who are older, they're immunosuppressed. Sometimes they say patients who are on long-term systemic steroids for whatever reason, let's say organ donor patients, I mean, organ recipient patients. But without having to go about this, we know for us here, HIV/AIDS is the most association. Now, the acute phase of herpes zoster ophthalmicus, the prodromal phase, they can it precedes the appearance of a rash 3 to 5 days. By 3 to 5 days, they'll present with a headache. Other things are non-specific, but the headache, and it will be the headache around the distribution of your ophthalmic nerve. So just to give you a quick story, during my days when I was working in Togoza as a general practitioner, I had a young lady coming with a severe headache, blood pressure normal, but I treated this patient as a cluster headache. I kid you not, before the end of the week, she came back with the florid vesicles along the ophthalmic division. So